For this afternoon, the title is pretty close to the published one, so you can all feel a lot easier. Okay, so just a little bit of revision from this morning, just to make sure that you remember what we said. So what we're doing with the CardioQ is we're using, hang on, as I said, this thing's more complicated than the CardioQ. We're using an esophageal probe. They're actually thinner than that now, and they inserted either into the mouth or the nose of the patient so that we can bounce ultrasound waves off the descending thoracic aorta, and we're looking at bouncing them off this relatively flat surface of plug flow, which enables us to generate a velocity time curve which is beautifully demonstrated here on the screen for you, which enables us to measure stroke distance, which is the area under the curve, and from that cardiac output. Now, this morning I did say this, but I'll say it again because it came up in one of the questions. The diameter of the aorta is unimportant because the calibration of the CardioQ from stroke distance to stroke volume was done by comparing stroke distances with stroke volumes measured with a pulmonary artery catheter. Okay, so it's got nothing to do with the aortic cross-sectional area. Okay, we'll start with the disadvantages this time. We'll change it round just to make sure you keep you on your toes. Okay, it requires access to the esophagus. Okay, so when you've got patients with varices or strictures, tumours, you know, it may be that little bit more difficult to use. Obviously, if you've got patients who are awake, then access to the esophagus is a little bit more difficult, but most patients will tolerate the soft nasal awake probe. Occasionally it can be difficult to focus when you have nasogastric tubes in situ, but one of the ways in which you can get around that is if you fill your nasogastric tube with a little bit of water so that there's no air inside the NG tube, then you can often get around the difficulty with focusing because of the NG tube. It's the air in the NG tube that causes the problem. It requires focusing, and it will require refocusing. It's not a technique that you just put it down and it's there for up to 10 days in an intensive care patient without you having to refocus it. And depending on the amount of movement, obviously the more movement you get, the more refocusing you will need to do. Focusing can occasionally be difficult, but it's only extremely difficult when you're trying to demonstrate it to someone important. That's when it will be most difficult. But otherwise, generally speaking, it's very, very easy to focus the probe. Obviously, if you get an air interface between your aorta and your esophagus, then this will obviously make the device have difficulties in focusing because the air will obviously interfere with the passage of the ultrasound waves. And this is true in open chest surgery, as it is if you've got surgery into the chest from below with a laparoscope. We do a lot of our hiatus hernia repairs, even giant hiatus hernia repairs laparoscopically, and at times the carbon dioxide from the abdomen can get in the way, and it can be intermittent. So those are disadvantages. And there are more disadvantages, of course. It does require flow in the descending aorta. So when you have a cross clamp on the aorta for that period of time, so if you're doing vascular surgery, you will obviously not be able to get such good readings during the cross clamping time, but of course you've got plenty of time before the clamp goes on to optimize the patient, and plenty of time after the clamp comes off to optimize the patient. But during the cross clamping, it can be difficult. As with the other techniques, the balloon pump can cause difficulties, and obviously the more rare problems of cooptation and thoracic aneurysm will obviously make it a little bit more difficult to use, and you may well get readings such that you would wish to discard them. Occasionally patients end up outside the nomogram limits. These are patients who are really tiny or really tall or really overweight, and if you find that, then you can use your stroke distance to optimise the patients, because if you remember that the stroke volumes and things actually come from stroke distance, and stroke distance is an actual measurement coming directly from the ultrasound and the aorta. So you can optimise your patients with stroke distance. Or the other little trick is that you get the patient's height, weight and age as close to the close to their own height, weight and age as you can, but within the nomogram limits, and accept that there may be a small error there. You can use the CardioQ. We were talking about paediatrics, weren't we? The CardioQ-P goes down to just 3 kilos, and I was very privileged. I was allowed into theatre in Madrid for some paediatric cardiac surgery, and we managed to have this 3 kilo baby having cardiac surgery, and there was a right to left shunt which was being clamped, and so we had a stroke volume of 4 mils coming up nicely on the CardioQ-P, just 4 mils. It was really very tiny, and the surgeon said in perfect English, which always amazes me how people who don't speak English as their first language can speak perfect English, and I can't speak anything else. I'm very embarrassed. He said in perfect English, if your machine works, when I put a clamp across this shunt, the stroke volume should rise, and it instantly went up from 4 to 7 mils. Very, very good demonstration of how sensitive that particular device is. So that was it, the disadvantages. So now we're on to advantages. It's non-invasive, a soft nasal probe is very well tolerated, it's so easy to use, it's very, very quick, and on our intensive care unit it is nurse-led. The nurses do the cardiac output measurements, we don't have to get involved, we just have to try and work out what to do once we have the figures. And it's a very short learning curve. And here is me focusing the probe, if I can make it work. Yeah, here we go. Now this is me in real time focusing a Doppler probe, just to show you how easy it is. It doesn't project enormously well till the signal follower comes up. So here we are. You'll see the triangles coming up, as we say, and I'm just going to put on the what's called the peak velocity detector, which is a blue line, which is to help you focus the probe. The idea is to have it such that the blue line is as high as possible. I'm going to switch that off now. Then I'm going to hit the auto gain button, and the auto gain button is an automatic way of getting the signal to noise ratio optimal. Okay, and after 30 seconds or so, the follower turns green. There we are. And in a second or two, you'll get your cardiac output reading. There. How long was that? A minute? It was about a minute, wasn't it? I don't think there's anything quicker than that to get a cardiac output reading. So if you're in the emergency room or something is happening that you don't like in the operating room or on intensive care, you can have your answer within a minute. Oh, and now we've got to try and work out how to get on to the next slide. It's going to be difficult. Next. Right, there we are. There's no calibration required, and so you don't have to faff around. It's ideal, therefore, for the operating room, ideal for intensive care. It doesn't, we don't have any problem with muscle relaxants. You don't have any difficulties whether the patient's on or off a ventilator. And the accuracy of it is not upset by changes in vasomotor tone. So, and in fact, the supplementary information you get from your peak velocity and your corrected flow time that we discussed this morning can be very useful. There's no problem with patients with AF because, as I said this morning, all you do is you average over a longer number of cycles, so that's not a problem, and you don't need to stop if you're hemofiltering patients. And it's cheap. If you're going to use your cardiac output monitoring for 10 days on a patient in intensive care, it's only about 15 euros a day. So it's a bargain. I don't know what they're priced at in the various countries around Europe, but in the operating room, probably about 100 euros for all those advantages that we discussed in terms of reduction in complications. There's no requirement for invasive lines, central lines, arterial lines, or PA catheters. Think how much your central line costs if you're paying 500 euros an hour for your operating theatre time. You're, by the time you put your line in and got it all sorted out, that's half an hour gone, isn't it? It's already 350 euros before you've even paid for the line, so much cheaper. Now again, this was in from this morning because we had a couple of questions on it. Remember that you can have quite big hemorrhages, quite big reductions in circulating volume with your systolic blood pressure staying the same, because that is what we are designed to do. We are designed to keep our blood pressure up, to keep our cells going in the face of hemorrhage, because it's a survival thing, isn't it? But it's at the expense of our gut. And if you remember, we discussed that if you're below the line on this PHI during major elective surgery, you will be more likely to be in a group with high complications and poorer outcome. So this is a further demonstration of why the CVP is completely useless in the operating room. What does it mean when you go on and off a ventilator, when you add on the PEEP, when you go head up, head down, belly full of gas? Yeah, what does it mean? It can't possibly mean anything useful at all. So again, we come back to our screen that I showed you this morning, and just to show how sensitive it is on a beat-to-beat level, we have an ectopic beat here, and you'll notice this little fella here has come in quite quickly following the one before. Small amount of filling time, small beat. That's pretty straightforward, isn't it? But the interesting thing is, following it, there's a compensatory pause, which is extra filling time. Okay, and you notice that the post-ectopic beat is far bigger than the normal beats. So this shows you that there is capacity within the heart for more filling. So just a little check. And again, if you use the stroke volume optimization technique, you will reduce the length of stay that patients have in hospital after any type of surgery. Every single research study, any type of surgery, all showing a reduction in stay or reduction in complications. This is the study we did in Worthing. We called it the WORM study in Worthing, the Worthing Optimization Research in Major Surgery. The branding got taken out by the journal in the publication process, so now it's called the Wakeling study, but then I can live with that. And it's a prospective double-blind randomized controlled trial with 128 patients, and we use the Doppler fluids. But the reason I want to bring this to your attention is that we actually controlled our control group. And our control group had the CVP maintained 12 to 15, which at the time we were developing the protocol was considered optimal therapy. So we compared Doppler fluids against a control group with conventional optimal therapy. And no one else has actually controlled a control group in any of these optimization studies at all. And we got some money from the government, which is a miracle. So just as we said before, 250 ml boluses. If you get the a stroke volume rise of 10%, you go back and give another one, having waited 5 minutes for to look for the result. Exactly the same as before. The CVP is in there because all patients had a CVP in this study, but the principal thing was the stroke volume 10% rise. And the patients only had about 500 mils extra colloid if you look at things overall, but the ranges were huge. Now some of these, obviously at the top end, in fact in both groups, is where the surgeon has hit something big, and we've lost an awful lot of blood. But you can see that generally speaking the range is quite large. But the other thing that's really interesting is that they had a median of 500 mils extra in, but over the first 24 hours or so we had 900 mils of extra urine out. So I think what's happened here is that because we had so much better splanchnic perfusion, we reduced the stress response, and so we reduced this desire to retain sodium and water. So we didn't have any problem with the urine output afterwards in these patients. But these are quite interesting. You see, in our control group, at the end of the surgery, which is, they hadn't had the optimization that the other guys had. You see, there's a big difference in proportion between the stroke volumes, the cardiac outputs, and the oxygen deliveries. You see, we're up to 535 mils per minute per meter squared, and this is only using fluid. There's nothing else in there, there's just fluid. So our oxygen deliveries were coming up towards the magic shoemaker number, but without anything other than fluid. And the gut started working earlier, and the patients went home earlier. And this was the only difference, was the Doppler-guided fluids. There was no difference. Everyone was blinded. No one had any idea who was in which group. But of course, our friend the CVP didn't change at all. Now, what we've got here is values at the start of surgery where they've come bowel preps and dehydrated, and values at the end of surgery for the group that were optimised. And you notice that the oxygen delivery, the cardiac output, and all those good things have gone up with optimisation, but the CVP has not changed. So the CVP has been unable to give you any idea about the haemodynamic parameters there, which are important for outcome. These are the ones that are associated with better outcome, and the CVP did not show that at all. Gut complications, absolutely predictable. You see, we saw that 55% figure from the Duke study. Here we are, 45% of those patients had gut complications, which included ileus, included not being able to eat at 7 days, whereas only 14% in the Doppler group had these problems. And that's a risk ratio of 5.3 to 1. And again, we looked at this morning, didn't we? The idea that this is from the very similar Noblet study, the idea that the patients in the protocol group are able to raise their cardiac indexes to match oxygen delivery with demand, whereas the control group were unable to do so. And our mortality in our study was 0 at 30 days against the national mortality at the time, which was published at 7.5%. Now, Worthing is a place where there's a lot of very elderly people. Some people say Dover for the continent and Worthing for the incontinent. And so a lot of these patients were ASA 3 and 4 that were actually enrolled into this study, and despite that we had a mortality of 0. What's going on now? Oh, there we are. And now, of course, we have put in the whole of the enhanced recovery after surgery package, of which the Doppler fluid started us off, and we've got everything else running now. And you might be interested to know that our length of stay has gone down for colorectal surgery to only 5 days median from 12 and above before. So that's what can be achieved if you get your fluids right. And compared with the rest of Britain, the Worthing Enhanced Recovery Programme is down here, whereas these are the length of stay for those who aren't following these sorts of processes. We'll skip that. The government are now discovered it, you see, because it involves saving money. So the government are now on board, and they did a very complicated economic analysis. I had my own economic analysis when we put the paper in, rejected as a back of envelope. But the government say that in the worst case scenario, you can only save £642 every time you use a Doppler probe in a patient having major surgery, but you could save up to 4,000. And orthopedics, now none of us like to see orthopedic patients in our intensive care unit, do we? Because they come along and the orthopedic surgeons never visit them. So if you look at elective hip patients over 70, 2/3 of them have gut problems going on right through the week. And if you Doppler them, they go home earlier because they feel better, all right? And this particular patient here had one hip done, I've got 1 minute left, okay, one hip done when I wasn't there, and one hip done when I was back, you see, and she had 2 litres of Hartmann's for her first intraoperative fluid management, and when I came back she had 1,500 mils of jello with pushing the stroke volume up to 112 mils. Now she crashed in recovery after this fluid management. So this is what we were saying earlier. You see, you can Doppler guide the fluids, but you don't end up necessarily with more fluid overall. Anyway, she ended up 5 days on the general surgical ward when I hadn't been involved, but she was eating and drinking normally day 1. And finally, intensive care outreach. Intensive care outreach is when senior intensive care nurse specialists go to review patients on the ward who've had problems highlighted. And certainly in one UK hospital in Colchester, they've initiated Doppler-guided fluid resuscitation, which of course means there's no delay in treatment. And they think they're preventing ITU admissions, avoiding inappropriate central lines, that sort of thing. And in their first 20 probes, they saw 24 patients, 6 of which they didn't think were adequate candidates for intensive care. So the other 18, they used Doppler-guided fluids, and they think they prevented, out of those, 10 ITU admissions completely. And in the others, they were the ICU admissions was purely justified. So what they've done here is they've prevented 10 patients coming to intensive care by getting on top of these problems early. And I think that's something which we need to see with our intensive care patients. We need to get at them as early as possible. So there we are, there's our summary. Okay, I'll leave it there.
Very good, thank you.